3, 2, 1. Needle pod.
Needle pod. Oh, I went slower. I'm sorry.
Damn it. But we're keeping it. We're not going to redo that.
All right, I'll know to go faster next time.
Yeah, I mean, that's why I did the 3, 2, 1, so we could be
I
like,
know.
needle pod. Our second time on the mic, and I really look forward to our little mic sessions. So needle pod number 2 coming at you. And I have to start with some bad news, Ellie. Maybe you were aware, but it has come to my attention that we actually didn't invent the term pod squad.
Dang it.
There's a reality dating show on Netflix called Love is Blind.
Yeah.
Have you heard of it?
We are invested in Love is Blind. It is one of the shows that Brian and I watch together.
Well, then they call themselves the pod squad because you live in a pod.
Yeah.
Before you meet. Is that how it goes? You live in a pod and you finally meet?
Yeah, you date in pods. So like there's a wall between you and they're called the pods. And I didn't really think about it as the pod squad. But I guess they do call themselves the pod squad. That's unfortunate.
So I'm not sure if it's trademarked or whatever. I think we can still be the needle pod squad. And I like how that sounds.
I like that better.
That was the name of our first episode, was Meet the Pod Squad, which was you and I.
Yeah. Well, bummer.
So what is more cringe? What gives you more ick when you're scrolling through on social media? Is it if you see a needle like buried, like shaft deep, especially like in the spine or the thorax? Or is it that needle that there's like 4 or 5 inches sticking out where it's like they used a 105 when clearly a 30 mil would have been long enough?
Honestly, I think it's more cringe when I see something sinking over the thorax. Like, to me, I guess that's not cringe. To me, that's sus, right? That's like,
okay.
What are you doing over there? I guess the cringe piece of it, which cringe and sus are different for those that don't.
I'm now tracking. I wasn't before.
So I guess the cringe is like, yeah, like when you're seeing 6 inches stick out of a needle, that's probably pretty cringe. I will say I don't see that a ton on social media. Like maybe people aren't posting their cringeworthy needle placements, but people do post some sus needles on Instagram.
Sure.
Yeah.
For sure. I mean, if it's like people you follow, maybe you treat similarly, but if you ever just like randomly search dry needling on social media, there's some wild stuff out there.
Yeah.
Speaking of, let me give you another one. What's more cringe is it's going to get more extreme. Needling through clothing.
Ugh.
And I know that's a tough one to combat. So let me say that or wet cupping.
So let's talk about wet cupping. Does that technically mean that that's not needling, that's not cupping with a needle in it, right? Because I've seen that.
I don't think so. It's the cupping where it's like extracting blood. I think on purpose, but yeah, suctioning, and then you see that the cup is actually filling up with blood.
I mean, I think the clothing is cringe.
Yeah.
I think that brings the cringe meter. I'm like, what are we doing? Especially glute tissue. I'm like, you just have to pull those shorts down a little bit, The wet cupping, I just don't know enough about it to call it cringe or not, but I would say the clothing needling is definitely on the cringe factor high.
Yeah. Well, look up wet cupping. It's a good comparison because I'm the same. Needles through clothing and I mean, never a good idea, but sometimes you're like, okay, looks like a tight fitting yoga pant versus like denim, which is still out there. But I mean, either way, don't do it. If you're listening on social media, if you do it in the quiet of your own room, but just don't put it on social media. There we go. That is the top cringe for Ellie,
sure,
for most of us.
Yeah.
So today we're going to stay on cringy topics, I guess, because I think what I'd like to unpack adverse events, I guess, from needling, but on our courses, when we start to talk about safety and adverse events from needling, one of the studies we unpack is the Boyce et al. Study, 20,000 sessions, like minor and major adverse events. It was a self-reported survey from practitioners, not patients, but we tee it up actually that the conclusion, the abstract highlighting answer, I guess, to that survey was that there was a 37% chance of an adverse event. And even I think I posted something on social media it's like a clip of you teaching where you're like, gulp, like that's a lot.
Yeah.
Like that's 4 out of every 10 getting an adverse event. But obviously, we unpack what that means, and that's bleeding, bruising, and soreness, maybe from a group of therapists that are more aggressive with the needle being pistoning versus less aggressive using e-stim or just placing it. So, I mean, that was the point of the post. It's worth bringing up on a needling course for sure, just to say, bleeding, bruising, soreness can definitely occur. And we kind of pull that right into the dosage and like technical, like how we use a needle. But what I'm going to bring up today is there was clearly a troll or a patient, call him a troll, that had a bad experience from needling. And I mean, we kind of went back and forth on this Instagram post. I'll just read the beginning of his first one. Clearly not a fan. He said, I vomited and passed out during my first treatment. Felt like shit for a week. Only made my muscles more uncomfortable, blah, blah, blah. And then went into like, PT shouldn't be doing this. It's unsafe. We should be sued. So, I mean,
Great.
yeah, what is your response to that? What are some of the bad outcomes that you have seen in the clinic?
Yeah, and I'll preface this with I haven't seen a ton of really negative outcomes. I've never actually had a person faint or get dizzy or any of that vasovagal response that you might see with needling. So that's a positive. Where I have seen issues is with a couple patients that um, get a nervous system response, but it's more GI discomfort. So they'll either feel a little bit nauseous, or I've had patients that actually have to run to the bathroom afterwards, getting some peristalsis going on. And the
Top or
same
bottom?
patient, bottom. Yeah. So
Interesting.
so they've and it was like 3 times in a row. The first time we chopped it up, she had Chinese food for lunch right beforehand, so I was like,
Yeah.
maybe that was it, but then it happened 2 more times, and we were doing some lumbar and then sciatic nerve stim, and so I think it just kinda triggered the sacral plexus and, yeah, really got her going there. So,
Do you
yeah,
think I
that
was
was
gonna ask, and you kinda just answered, but do you think that is more common in a certain region or with treating certain things?
Yeah, so I mean, in theory, and I'm going into this more in my course, but in theory, when we're talking about bladder, bowel function, we're stimulating sympathetic nervous system and we're inhibiting parasympathetic nervous system, and then we have all this other stuff going on when we're needling around the sacrum itself. So I think definitely happening for needling in the TLJ, we might get some sympathetic nervous system activation. And then if we're needling around the sacrum, I think that also plays a role into that parasympathetic nervous system. So there is research to support that we do stimulate those nervous systems. And so I think that's if we're in the spine area, that's more where I would see it. Yeah.
Makes sense. And I'm sure you
Yeah.
have a very positive reroute to the cleansing, the positive benefits of that potentially adverse event that someone might not be expecting from a needling session.
Yeah. Yeah. I mean, I just point like I'm like, okay, if this is an event that we don't tolerate very well, we pivot, right? And we don't always have to do needling in that area. We can go peripheral or like distal or proximal to the area and see how that affects their nervous system as well. Which he has tolerated needling in other places without having that response. So that's kind of where we pivot. And then also saying, this isn't the only tool we have in our toolbox as physical therapists. And I think that's what's so cool about our profession is we have so many tools that some people just might not tolerate the needles well, which is a hard pill to swallow for me because I love dry needling so much.
For sure. And I have a follow-up question there in a minute. But yeah, I mean, if you're listening here and you needle at all, you see stuff. And I mean nervous system stuff. Sometimes it's just kind of the heavy sweater, like the person that sweats heavily from the needling. Yeah, I have definitely heard the people that it stimulates some GI stuff. I mean, I've been needling long enough. I've been teaching needling long enough. I have seen multiple people faint. I mean, vasovagal syncope, like a needle-based aversion, it's a real event for sure. I mean, it's not just obviously there's emotional, psychological layers there, but it's not someone who's making it up. It's an actual cardiac and it's a real event. What's surprising, I've only had 2 of my own patients faint. What's surprising to me is they were both in the same year before I used eStim. They were both Division 1 soccer guys treating the hip, I mean, region of high dysfunction like adductors, and one was rectus femoris. The common thread aside from those 2 things was late morning or early afternoon session where they didn't eat breakfast or were fueled only on coffee. So I think that there's a kind of I don't know, a blood sugar component to it. But yeah, adverse events happen. It is tough when we kind of land where you did, which is needling is not necessarily appropriate for every patient. So I think on a future episode we'll unpack like if you were forced or if you weren't allowed to use your needling on a certain patient, what would you do? That's a great
Yeah.
topic.
Yeah.
But the similar question I want to ask is what discussions do you have if the patient from social media walked in, had a bad experience with needling, and you start talking about needling and you start getting the like, nope, like I've had a bad history with that. What sort of conversations do you have with your patients?
Yeah, so first I educate that not every needling looks the same. And so I'll break down and I'll kind of see what their previous experience was. And then I'll educate them on how we needle and how it might be a little bit different. You know, we're pistoning a lot less. We probably use fewer needles than trigger point trained needler would. And then we're layering in the E-stim, which is if they've had, you know, chronic pain and they may have been introduced to like a TENS unit, I'll say that it's similar to that. We might get some muscles contracting and relaxing with it. So I start with kind of breaking down their previous experience and trying to educate on how it might be a little bit different. And then I kind of talk about the why behind the dry needling. And say that not every single experience is going to be the same, but that our ultimate goal with dry needling is to calm down the nervous system. And it sounds like last time you may have had a heightened response with your nervous system, which isn't going to happen every single time. And so that's kind of how I pivot there. And then what I let them be the decision maker. I'm not going to force anyone to get needled. I'll put the ball in their court and I'll say, you know what, we can try it today. If you hate it, we never have to do it again. But I'll put the ball in their court. And then I also give them the option of like, you know, we have a ton of other tools as physical therapists. Let me try some of my other tools first. And if I still think we would benefit from some dry needling down the road, I'll bring it up again. So if they kind of decide on that first session or whatever session I introduce it with that they don't want to go the dry needling route, I'll still let them know that I'm probably going to bring it up in the future. Just, yeah.
I like that. So you're getting someone that clearly is not a fan of needling or is even giving you a hard stop. I liked where you ended, which is you still have to bring it up as an option. You know, Gladys, here's what I think's going on. There's a few ways we can approach this. I mean, I've seen great success, or a lot of people come to me for this, for the dry needling stuff. So that's an option. You're getting a stop sign from the patient. There's other things we can do, a more movement exercise based, which is going to be a part of any of the plans, but we could go purely that route or other manual techniques, that sort of thing. But you brought it up. And if you get 3 visits, 6 visits, 20 visits down the road, and that patient is frustrated that we haven't made progress and their brain and their questions to you start going down the surgery, injection, medication route. It's like, remember, we have one more thing to try before that. And especially if you're talking injections and surgery and medication, now is the time to consider that thing being a needle that totally understand you were not the biggest fan of, and we wanted to try some other stuff first. The other thing you said, which is important, is, and we talk about this every weekend and on every course, is like, man, dry needling is it's an enormous umbrella. How many needles, how aggressively they were used, what was done before and after. So honestly, whether a patient is a huge fan or the opposite of like, oh, I loved dry needling, I hear you do dry needling, or nope, I tried needling at this clinic and it was horrible. Way more info to gather, way more questions to ask, like you said. How aggressive was it? How sore were you? What did they treat and how did they treat it? Did they use E-stim? What did they do for the rest of the session? And I mean, yeah, I'm not saying that you're going to have a win with every patient. I mean, I don't think I won this Instagram battle with this guy, which is fine. I'm not trying to convince him to go back and get needling, but good conversations to be had.
Yeah. Yeah. I think that's all great points there. But yeah, it's definitely something that you run into. And so knowing how to navigate that is the first step, right? Um,
So if Boyce et al. Said 37%, almost 4 out of 10 patients, you get some of that minor adverse stuff, soreness, bleeding, bruising. What's your percent? What's the Ellie Melrose? How many of your
hmm.
patients get some bruising, some soreness, or something like that?
I would say that I have started pistoning a lot less. So that's one thing that I have done a lot less over the past few years. And so bleeding is pretty minimal. I'll get it once a month, maybe once every few weeks, right? Where I get a small capillary interaction or, venule interaction, something like that. So then I might get a bruise again, maybe once a month or once every other month, something like that. And my verbiage is I typically will tell patients, like, you might be sore for up to 24 hours, but typically what I find is that people are not sore for even 24 hours or longer than that. For, I would say, 99% of the patients that I treat, is that soreness reduces. And I think there's a couple different reasons why. It's like, yes, we're pistoning less, so we're not creating as much micro trauma. The E-stim definitely layers in a piece of that pain modulation. And then I think that really the loading strategies are giving them some exercise to get moving afterwards, and introducing those movements as this is going to help with that post-treatment soreness is also something that I think is why my patients are a little bit less sore after needling. And again, once in a blue moon, I'll get someone that was like, wow, I was sore for like 72 hours. And that's just in my documentation. I'll look back and I was like, okay, that was an overdosed needling session for them.
Just
So,
crushed medial gastroc or upper
yeah,
trap too hard.
something. Yeah. Or it's just, some people tolerate the needling stimulus a little bit different than other people. And so just with their nervous system response, and some of that can be pain, which maybe that's how they tolerate every form of manual therapy too, is like you always have to maybe err on the side of underdosing for those folks. But yeah.
Yeah, it's crazy to think back to myself of, yeah, when I wasn't using E-stim, more aggressive, like twitch response based treatments. So that was the key and the goal. And if I didn't get a twitch in 10 seconds, then we were going to be pistoning for 20 seconds. And honestly, even at 10 seconds, if I already have 2, 3, 4 twitches, it's like, well, let's just keep going. So, I mean, back in those days, I almost think 37% was light. Like I was teeing up Gladys for like, you're going to feel this. We're treating
Yeah.
unhealthy tissue or whatever. Like, the microinflammation we're causing is a benefit. Like the body will come in and repair it and all that stuff. So I was good at explaining the soreness, but I was also good at delivering it. But it's crazy to think now, especially the soreness with patients, I almost feel so strongly the other way of like, no, you're really not going to be sore, like almost at
Mhm.
all. Like if I'm seeing an NFL guy for recovery in season, I am tiptoeing my needle in. It's only E-stim, no pistoning. I can almost guarantee no soreness. That doesn't mean like the needle's in feels great. Achy, crampy sore is still the sensation there, but I can almost guarantee no soreness versus my old self could almost guarantee soreness for every patient. And I think that's the E-stim. The other snapshot is like, I just finished a 3-day needling course. So I watched a room full of PTs get needled full body for 3 straight days. And I mean, there's some folks where that's a lot. It's a lot of con ed. Like it's a long course. It's a heavy mental lift. Your nervous system is maxed out in multiple ways, but not really soreness from the needle, which is
Mhm.
amazing. Because that's not even a PT session. That's like learning some new techniques, then doing it and sitting in a chair, then learning some more techniques and then doing it and then sitting in a chair. Like it's not like that 2 to 4 needles treating dysfunction that you then do a manual therapy technique, that you then do an exercise, that you then, by the time you're at the end of your hour session, you kind of forgot about the needling entirely. Like literally just watching groups of people be needled all day for 3 days straight, and still soreness is not really a major complaint. And that has to be the E-stim. I mean, that's
Yeah, for sure.
not everything else.
I think
We
the
also,
one piece of that is at the end of the day, I'll poll people, like, when I'm teaching and say, "All right, what do we feel soreness in?" And if they're saying, "I have lingering soreness from my lateral elbow," or something like that, supinator gets everyone, right? But then we go load it afterwards, right? And that's what's different with ice physio, is that we end the day with a workout, and so by the next morning, most of the time, they're not sore anymore after, like you said, needling a third of their body in one day. So yeah, it's definitely E-stim and movement, I think, are the go-to for reducing that.
hell yeah.
Hell
So
yeah.
if you've been tuned out this whole time, we're not needling through clothes or wet cupping. Needle length, we hate to see it buried to the hilt in the thorax. But otherwise, you're going to have patients that are not on board with needling, and that's okay. I still would encourage you to tee it up as a treatment option down the road compared to traditional medical stuff. But you're still going to have some folks that have had it before. And I think have the conversation. Potentially, what you're going to deliver is going to be different from that. And then, I think you and I fully agree the e-stim and the loading is really how you can mitigate a lot of those. Didn't love it last time because I was in some physical distress for 24 hours afterwards.
Yep. Agreed.
Hell yeah. Fist bump. It's the end of pod 2. Catch you next time,
Awesome.
team.
See ya.